I want to welcome every one of us to the 7th series of the anatomic series that we have begun now for some times. So today we'll have a medical student from Zambian to take us through the basal ganglia. So as we all know, I'm going to start by allowing all the panelists to introduce themselves, and then I'm going to hand over to the presenter. He will introduce himself, and then he's going to start the presentation. So I'm just going to call the names here as it appears on my list. So yeah, sorry, by the way, I'm Tunde Obatoke. I'm a fifth-year medical student at the College of Medicine, University of Lagos. I'm a member of AFAN and I'm a research fellow at AFAN. So I will just call the name as it appears on my list here so that every one of us can also introduce ourselves. Then I will hand over the mic to the presenter. So can I have Claire Jongwonin? Can I have you introduce yourself? I'm so sorry if I'm not pronouncing the name correctly. Claire Jongwonin, right? I'm not sure if I'm actually pronouncing it correctly. But if you can hear me, I would love that you unmute your mic and you introduce yourself.
I'm Claire Semtai, medical student, Kenya, second year.
All right, you're welcome. Okay, can we have Emmanuel Mukambo? Can I have you unmute and introduce yourself?
Hello, everyone. My name is Emmanuel Mukambo. I'm a fifth-year medical student at the Coventry University in Zambia. I'm also the Assistant Grants Development Officer of the Association of Future African Neurosurgeons. I'm glad to be here. Thank you.
All right, you're welcome. Can I have Sakoya? Can I have you introduce yourself?
Good evening, everyone. My name is Musakanya Shituruka, a final year medical student from the Copperbelt University, Zambia, and I'm also AFAN's country representative for Zambia. And I'm glad to be here.
You're welcome. Can I have Nyantu Sakaiwa?
Hello, everyone. I'm a fourth-year medical student from the University of Botswana and also an AFAN country representative for Botswana and an AFAN research fellow and one of the communication team members for AFAN. Thank you.
You're welcome. Can I have Wak Solomon Charlie? Can you unmute and introduce yourself?
Hello, everyone. My name is Charles Waxman, a third-year medical student at the Copperbelt University, a member of AFAN. Thank you.
You're welcome. And can I have Abdul Wakil Muhammad? Okay, it seems he's not connected to the mic, so I'm sure he can't really hear me right now. So also today, I'm so glad to have Dr. Kabulo in our midst. Dr. Kabulo, you are very much welcome today. We're so glad that you take out your time to join us again. I would love, sir, if you can unmute and introduce yourself.
Thank you so much. I'm Kabulo, consultant neurosurgeon in Lubumbashi, Democratic Republic of Congo. Hello, everyone.
Welcome, sir. So glad to have you today. So right now, I'm just going to hand over to the presenter for today. So he's going to introduce himself, and afterwards, he's going to begin his presentation. So Ebenisha, you have the floor now.
Thank you so much, and thank you so much, everyone, for coming in. My name is Ebenisha Majata. I'm a fourth-year medical student from the Copperbelt University, Zambia. I'm going to share my screen, and you just confirm with me when you're able to see my screen. Are you able to see my screen?
Yes, I can see your screen.
All right, thank you so much. So just as I said, my name is Ebenisha Majata, a medical student from the Copperbelt University School of Medicine. Our topic of today for discussion is the basal ganglia. So some of the objectives for today are, we're going to look at the structure as well as the nuclei or the basal ganglia. We'll then look at the connections of the basal ganglia as well as the functions of the basal ganglia. Then we'll end with the clinical relevance of the basal ganglia. So this diagram here just shows the nuclei that makes up the basal ganglia. So I'm sure we're able to see in green, we have the thalamus. In red, we have the globus pallidus. Now the globus pallidus, it has two, it is a pair. So we have the globus pallidus externus. We also have the globus pallidus internus. So we'll be able to see the functions of these two. We also have in blue, that's the substantia nigra, and in yellow we have subthalamic nucleus. We also have the stratum, and the stratum is made up of two. So we have the caudate nucleus as well as the putamen. So what are some of the general functions of the basal ganglia? So I'm saying the basal ganglia is part of the extrapyramidal motor system. It facilitates behavior as well as movement. It inhibits unwanted and inappropriate movements. So the basal ganglia plays a role in starting and stopping movements, as we shall see in the next slides. The diagram here just illustrates the nuclei that makes up the basal ganglia. Now, by definition, we know that a ganglia is a group of cell bodies that are located outside the central nervous system. And the nuclei is a group of nerve cells that are located within the central nervous system. But in this, we're going to focus much on the basal ganglia. We won't use basal nuclei, though basal nuclei is more accurate. I will stick to basal ganglia. So each side of the brain has a pair of nuclei. So as I said, we have the caudate nucleus, the putamen, the globus pallidus, which has two, globus pallidus internus, globus pallidus externus. We also have the substantia nigra, subthalamic nucleus. Now, for the basal ganglia to work or to operate, to control voluntary movements, it needs neurotransmitters. So the neurotransmitters of the basal ganglia is classified in two. We have inhibitory neurotransmitters as well as excitatory neurotransmitters. So these neurotransmitters include dopamine, GABA, glutamate, acetylcholine, as well as others that include norepinephrine, serotonin, as well as enkephalin. But we are going to focus much on those as well as glutamate in this. So we have a pathway that is going to activate the cortex and a pathway that is going to inhibit the cortex. So just as I said, the pathway that is going to inhibit the cortex is the indirect pathway, and the direct pathway is one that is going to actually excite the cortex. Now we're going to start with the direct pathway. On my right, you're able to see a glutamate there. So from the cortex, glutamate will be released to act on the stratum. Remember, we said the stratum consists of the caudate as well as the putamen. Now, glutamate acts on the stratum and excites it, since we are saying glutamate is an excitatory neurotransmitter. So once glutamate acts on the stratum, in this case, we shall use the putamen. Upon acting, putamen is going to produce GABA, as we can see in red there. So this GABA is an inhibitory neurotransmitter. GABA is going to act on globus pallidus internus or substantia nigra reticulus. Now, the globus pallidus internus also produces GABA. Now we have two inhibition here. So we have inhibition from the putamen and inhibition from the globus pallidus internus. So we are disinhibiting the inhibition. So what is the end result by disinhibiting the inhibition is actually we're exciting the thalamus. So once the thalamus is less inhibited by less GABA that is produced from the globus pallidus internus, what we expect is more glutamate to be released from the thalamus to the cortex. As we said, glutamate is an excitatory neurotransmitter. So it is going to excite the cortex. As a result, the cortex is going to provide the movement. So also have a pathway that acts in an opposite manner, and that is the indirect pathway. So with the indirect pathway, it also starts with the cortex. That is on my left now. So the cortex is going to release glutamate, and glutamate is going to act on the putamen so that the putamen can produce GABA. Now, GABA this time around is going to act on globus pallidus externus. So the GP is the globus pallidus externus. It also releases GABA. Now, again, GABA acting on globus pallidus externus, it is inhibiting it. So the globus pallidus externus is going to produce less or little GABA. As a result, the subthalamic nucleus is going to be less inhibited. As a result, it is going to release glutamate. Now, the glutamate that is going to be released is an excitatory neurotransmitter, which will act on globus pallidus internus. Now, this time around, we are not inhibiting the globus pallidus internus, but we are exciting the globus pallidus internus. So what is the end result of exciting the globus pallidus internus is that we are going to have more GABA being released on the thalamus. So if more GABA is released on the thalamus, then we are going to have less glutamate being produced because it is being inhibited. So since less glutamate is going to be produced, we're going to have a stoppage of for the understanding here on the. Okay, so this is a simplified model just to depict what is happening in the direct pathway. So as I said, the cerebral cortex is going to produce an excitatory neurotransmitter, which is glutamate in this case. And glutamate is going to act on the stratum. The stratum produces GABA, which is an inhibitory neurotransmitter in red. Now, once it is produced, the globus pallidus internus is going to be inhibited. So inhibiting the globus pallidus internus means we are producing less GABA here where there is X in black to act on the thalamus. As a result, the thalamus is going to produce more excitatory neurotransmitter. Now, another pathway that we can have is starting from the substantia nigra pars compacta. So the substantia nigra pars compacta is also going to release an excitatory neurotransmitter, which is going to act on the stratum, and the process continues. The end result is activation of the cerebral cortex and initiation of movement. So this again is just to show also the D1 receptor as well as the D2 receptors. So if you're able to see, the cerebral cortex releases glutamate, which acts on the stratum. Then the stratum is going to produce GABA, which is going to inhibit the globus pallidus internus, and the process continues like that. Now, another pathway, if you are able to see the substantia nigra pars compacta, it is going to release dopamine. Now, dopamine acts on two receptors. So we have D1 receptor as well as D2 receptor. So D1 receptor is involved in the direct pathway, whereas D2 receptor is involved in the indirect pathway. So if we are to check the one that is on orange, that is the D1 receptor. D1 receptor actually causes excitation, while D2 receptor causes inhibition. So within the basal ganglia, we have two major neurocircuit. We have the Peterman circuit as well as the caudate circuit. So we're going to look at these two circuits independently. So the Peterman circuit, saying this one controls the complex patterns of motor activity, e.g. learned skills. Learned skills, we can talk of cooking, playing soccer, also playing volleyball, even running. So it has inputs from the parts of the brain adjacent to the primary motor cortex. So outputs, they mainly go back to the primary motor cortex, or they associate themselves with the premotor and supplemental cortex. So there are situations in which we might have lesions to the putamen, and this will cause abnormalities in the putamen circuit. Now, the way the putamen exert patterns of movement is not really known. However, when a portion of circuit is damaged or blocked, certain patterns of movement become severely abnormal. So this includes Parkinson's disease, which is characterized by rigidity, akinesia, as well as tremors. Usually the type of tremors in Parkinson's disease are resting tremors. So lesions with the globus pallidus usually leads to athetosis, which is a continuous rhythm movement of the hand, arm, the neck, as well as the face. So we can also have the lesions to the subthalamus, and this leads to hemibarismus. So we'll look at what hemibarismus is in the next few slides. So we can also have multiple lesions to the putamen, which might lead to chorea. And chorea is simply flicking movements in the hands, face, and other parts of the body. The caudate circuit. So this circuit plays an important role in cognitive control of motor activity. It receives a large amount of input from the association areas of the cerebral cortex overlying the caudate nucleus. So these signals, they return to the prefrontal cortex, premotor cortex, as well as the supplementary motor areas. Now, the role is appreciated on seeing a lion. The response that follows is, so when you see a lion, you might turn away from the lion, and you begin to run, and even attempting to climb a tree. So all of this is coordinated by the caudate circuit. Now we come to the clinical syndromes from the basal ganglia. So these are some of the clinical correlates from the basal ganglia. We have Parkinson's disease, Huntington disease, hemibarismus, as well as athetosis and chorea. But here we're going to focus much on Parkinson's disease, Huntington disease, as well as hemibarismus. So this diagram just illustrates what happens in the Parkinson's disease, Huntington disease, as well as hemibarismus. So if we are to look at the normal circuit, we said we have direct pathway as well as the indirect pathway. So the defect in Parkinson's disease is in the substantia nigra. I think we're able to see on the bottom where the substantia nigra, which is in dotted lines. So once there is defect in the substantia nigra, neurons that are responsible for activating the putamen will be less, or there will be no neurons that will be able to activate the putamen. As a result, we will have features of resting tremors, rigidity, as well as other features that we looked at. Now, in Huntington's disease, the defect is usually in the subthalamic nucleus. But here, there is a defect in a gene on the 4th chromosome. the short arm or the fourth chromosome. So look at it as we go to the next slide. So the Parkinson disease is also called paralysis ejectans, which involves destruction of the portion of the substantia nigra, that is pars compacta mainly, and it is due to deficiency in dopamine. So what are some of the features of this Parkinson disease? So I said there's rigidity, involuntary tremors, which is involved, and usually we're saying these are resting tremors. The normal tremors is 6 to 12 cycles per second or hertz. But in this case, someone might have tremors even at a fixed rate of 2 to 6 cycles per second or hertz. So there are many different types of tremors, and these can be essential tremors, Parkinsonian tremors, as well as dystonic tremors. But in this case, we're talking about the Parkinsonian tremors. So tremors can also be classified as being resting tremor or the action tremors. So other features of Parkinson disease include akinesia, bradykinesia, which is just difficulties in making movements. There is also hypophonia, in which there is reduced speech, especially some people in public, they are unable to make proper speech due to Parkinson disease. So in this disease, usually there is lack of balance between muscles of contraction and muscles of relaxation. As a result, someone tends to be shaking, so to say, or having tremors, uncontrolled tremors. So what are some of the treatments that we can use in order to treat Parkinson disease? So we can use levodopa, which is usually administered with carbidopa. So the reason why carbidopa is administered together with levodopa, we're going to look at it in the next slide. So we can also administer the drug L-diprenil. We can also treat it with transplanted fetal dopamine so as to supplement the loss of dopamine, the damage to the substantia nigra pars compacta. So we can also treat it by destroying the part of the feedback circuit in the basal ganglia. We destroy the part of the basal ganglia that is actually affected. So this is the major reason why carbidopa is given along with levodopa. So we have the dotted line here, which shows the blood-brain barrier. So we have outside here levodopa. Now, outside the blood-brain barrier, levodopa tends to be converted to dopamine. And dopamine cannot cross the blood-brain barrier due to its high molecular weight. So we administer carbidopa to prevent this conversion. So once levodopa get entry into the blood-brain barrier, which I'm showing in green here, the green arrow. So we have levodopa inside the blood-brain barrier. So inside the blood-brain barrier, actually carbidopa promotes the conversion of levodopa to dopamine. So this is the major reason why this drug is not administered alone as levodopa alone, because it will be converted to dopamine outside, and dopamine has side effects outside the blood-brain barrier. So this is just to show some of the diseases and the point at which they act in Parkinson disease. So we are starting from the far left, where we have levodopa. So levodopa can be converted to dopamine, as we can see there. So the carbidopa will inhibit this conversion. Then levodopa can also be converted to other end products. And we use drugs such as tocapone Let me try to zoom in, as well as entacapone. Now, inside the blood-brain barrier, we have levodopa being converted to dopamine. So that dopamine can be used now to bind to the D1 and D2 receptors in order to promote either the direct pathway or the indirect pathway. Again, dopamine tends to leave the neuron before it actually reaches synaptic membrane where it is required. So to prevent that from happening, we can see here dopamine is converted to monoamine beta. So we have inhibitors such as selegiline, razagiline, which are actually given in order to prevent this conversion. We also have tocapone up there, which prevents that conversion as well. Now we can also use amantadine, which actually promotes the availability of dopamine. We can use drugs which promotes the binding of dopamine to the receptors. Such drugs are dopamine antagonists, and I think we're able to see them. We have bromocriptine, pramipexole, as well as ropinirole. So these are some of the drugs that we can use in patients with this disease. The next disorder that we are going to look at is the Huntington disease. So this one is a hereditary disease, usually due to a defect in a gene on the fourth arm of a chromosome. So symptoms of this disease usually comes in the third or second decade. And the first symptoms include flicking movements that occur in individual muscles and usually progress to severe distortion movement of the entire body. So dementia might also develop in this disease. So this diagram here just illustrates what happens in this Huntington disease. So we have the normal frontal horns or the lateral ventricles. I'm sure you're able to see in red in that arrow. Then here in blue, there is enlargement of these frontal horns or the lateral ventricles. So due to the defect in the Huntington disease, hunting gene, what will happen is there will be uncontrolled production of abnormal proteins. So some research shows that due to this defect in genes, there is usually production of proteins that more like forms clusters, and they clamp together. And during clamping, they destroy part of the basal ganglia. So in doing so, we have difficulties in memory. Dementia also sets in. So diagnosis of Huntington disease, we can use radiological modalities such as MRI or CT scan. You can also use neurological tests to look at the nerves. You can also look at the psychological tests to check the mental health of that individual. So we can also use neuropsychological tests in order to evaluate diseases such as obsessive compulsive disorders. And genetic testing confirms the diagnosis, since it is able to detect those abnormal proteins or abnormal genes. So some of the causes of Huntington disease include loss of cell bodies that produce GABA in the caudate nucleus and in the putamen. There's also loss of acetylcholine secreting neurons in the parts of the brain. And dementia results from the loss of acetylcholine secreting neurons. So under CT scan or MRI, these are some of the images that we have. So we have this patient here, patient 1. I'm sure we are able to see the caudate nucleus as well as the putamen here in patient 1, the far left diagram. So in this diagram, if we are to compare it with the second diagram, you'll find that there is atrophy of the cerebellum. So where those arrows pointing, it is the atrophy. Now, under patient 2, the drawing on the far right, this one is viewed under MRI. And here, we're able to see that there is a decline in the intensity of that caudate nucleus and the putamen. So if we're able to see where the orange arrows are pointing, and in the next diagram, we'll be able to see that there is that atrophy there. So that usually leads to Huntington disease. So it is important to note that Huntington disease occur in 4 to 5 persons per million, with age onset in the 4th and 2nd decades. So we're saying it is an inherited autosomal disorder fashion with complete penetrance. So usually there is a 50% chance that someone with Huntington disease can pass it to the children. And if the children acquires it, they also have 50% chance of passing it to their future generation. So the neuroimaging here simply shows the characteristic atrophy of the caudate and the putamen. The third syndrome we're going to look at, or the third disorder that we're going to look at under the basal ganglia, is the hemibarismus. So this is a relative rare hyperkinetic movement disorder that is characterized by, number 1, involuntary violent course and wide amplitude movements involving one. So usually it is caused by stroke, and normally subthalamic nucleus is involved. So this is just to show the pathophysiology of hemibarismus, or how it comes about. So this in plus is these are excitatory pathways, and in red we have inhibitory pathways. So again, just as we said, the normal pathway starts from the cortex. So the cortex will be able to release neurotransmitters to the putamen, and the putamen will also release inhibitory neurotransmitters to the globus pallidus externus, which is going to inhibit the subthalamic nucleus. Now, let's say we have a defect in the subthalamic nucleus. So it means the subthalamic nucleus won't be able to produce the excitatory neurotransmitter to globus pallidus internus. And in doing so, we're going to affect the way the pathway operates. So some of the ways in which we can treat hemibarismus include, if we are to look at diagram A, we're able to see that there is release of dopamine. Yeah, so dopamine is released excessively. Then it is able to bind on D2 receptors. Now, the aberrant downstream signaling will lead to psychosis. Our goal in treating hemibarismus is to prevent this excessive release of dopamine. So what do? We administer antipsychotics and psychotic drugs, which are going to, 1, they will block these autoreceptors, as we can see in red. So once these are blocked, and then there won't be more like a re-entry of dopamine in the presynaptic neuron. So another mechanism through which antipsychotics works is by blocking the D2 receptor. So they act as D2 receptor antagonists. So they will prevent the activation or the postsynaptic neuron. And in doing so, we are going to reduce psychosis.
Okay, thank you so much, Ebenisha, for the wonderful presentation. Just once again, I'm really sorry about the break in the presentation the other time. It was due to a network issue. So at this point, I'm going to allow us to ask our question. Let's feel free to participate and ask our question. So I can see a question on the chat box. So I'm going to read out the question. So it says there is a paper on Medline Plus, Medical June 23rd, 2020 on basal ganglia dysfunction, which states many brain disorders are associated with basal ganglia dysfunction. And this is due to the chronic use of medicines used to treat schizophrenia. So Adrian is asking that if you can enlighten us more about this, the statement. So I don't know if you would respond to that question now, or you would allow others to ask their question and then you respond later. So I don't know if there is any other question apart from this. Let's feel free to ask our question. We have Dr. Kabulo around as well to help us. So let's feel free to participate and ask that question. So do we have any other question or any other clarification or comment? Okay, so I think I will just allow Ebenisha to attend to the question. And he's saying that he also wished to know the main source of basal ganglia bleeding.
Okay, thank you so much for that interesting question. I'm not really sure about the answer, but what I came across when I was researching was that some of these drugs that are used in schizophrenia patients, they tend to inhibit the D2 and D1 receptors. And these D2 and D2 receptors, D1 and D2 receptors are actually dopamine receptors. So if we inhibit dopamine, then we're impacting the basal ganglia pathways. I think that's what I can say on that. I'm not sure if there are others who have proper answers to that.
Okay. I don't know if there is any other question. Let's feel free to participate. Dr. Kabulo, I don't know if you can help regarding that question. Perhaps you can help to clarify better.
Okay, thank you so much. I think I had the network problem. Those two questions, the first one, I think the answer has to come from that paper. Of course, many brain disorders are associated with basal ganglia, especially because when we are talking about basal ganglia, we see the extrapyramidal system. There's a pyramidal one and an extrapyramidal. We are seeing the extrapyramidal. But when they are talking about medicines used to treat schizophrenia, now we have to know in that paper, are they talking about those disorders in patients with schizophrenia or with in patient without that disease? I'm not sure about that, but I think we will read together the paper. So I will also try to look for that paper. For the question, he wanted to know the main source of basal ganglia bleeds. This is hypertensive bleeds. It means when you see the small arteries which are going to supply the basal ganglia, those arteries are coming from the main trunk, the middle cerebral artery. So the middle cerebral artery is a big trunk, and you see very small lenticular striate arteries which are going to the basal ganglia. When the pressure increases into the main trunk, the middle cerebral artery, the same pressure is transmitted to those small arteries. That's why they burst and you get basal ganglia bleed. And usually when you get basal ganglia bleed, it's hypertensive bleed. So I think I've answered to the second question. Thank you.
Thank you so much, Dr. Kabulu. So I don't know if we have any other question. Do we have any other question? Do we have any other question? All right. So in the absence of any other question, I think we can call it a day. I want to thank everyone once again for coming for the presentation. Thank you so much, Ebenisha, for the wonderful presentation. And thank you so much, Dr. Kabulu, for your presence and your contribution. Thank you, everyone.
Thank you so much for the opportunity.
Thank you, Dr. Ebenisha. Thank you very much. Thank you too to Dr. Kabulu for the enlightenment for the second question. Thank you very much.